Respected Dr. D.K. Hazra Sahab, Dr. Sachan Sahab, Dr. A.K. Gupta, my teachers, seniors and colleagues, I wish you a very good evening today. I also wish you a very happy World Diabetic Day. I wish those who have diabetes to remain euglycemic all their lives. Those who are not diabetics, I wish they never develop diabetes, and for the public at large, I wish they are also protected from diabetes by the best of care that we all physicians can provide to them. I am very grateful to Cadila Pharmaceuticals to have provided me the opportunity to talk on cardiovascular risk management, the present day challenges and the possible solutions thereof. There is a common adage that one who can treat common diseases is a good doctor. One who treats uncommon diseases is a better doctor. But one who can prevent the diseases is the best doctor. Dr. H.K. Chopra in the CSI Prevent conference, the first CSI Prevent conference that we had in Agra about 2 months back, said these lines. Between 1950 to 1970, what I believe, there was a stress on disease control. From 70 to 90, the stress changed from disease control to risk factor control. In the past decade, 50 to 70, only when someone would fall ill, they would approach a doctor and get themselves treated. But later on, there was a paradigm shift. Even before someone was afflicted with a disease, he would come to a doctor for risk factor control. From 1990 to 2010, we see another paradigm shift, and that is a stress on maintenance of health, the treatment of risk factors, the prevention of risk factors. Initially there was stress on risk factor control. Now we are thinking of preventing the risk factors, and thereby we are trying to increase the longevity. Despite all these paradigm shifts, we have a great lacuna. And the lacuna is, we are seeing an explosion of cardiovascular diseases. And the explosion is occurring in the region where we are, the developing world. What is the reason for this? Why is the cardiovascular disease population prevalence growing day by day? Probably the guidelines of disease management are not being followed, the patients are not being compliant, or there is some unawareness of the patients towards the disease, towards risk management. These are the challenges that we are going to face, and we are going to also discuss this evening about the solutions to these challenges. The current challenges for cardiovascular disease management includes a changing epidemiology. Initially, the cardiovascular disease were limited or more prevalent in the developed worlds. We are seeing a change. The developing world today sees more cardiovascular diseases as compared to the developed world. The age of cardiovascular diseases has changed. We are seeing cardiovascular diseases in younger population. The genders have also changed. Initially, about 30 years back, 20 years from cardiovascular diseases than men. Today, the queen of hearts are catching up, and they suffer from cardiovascular diseases to the same extent as the male population. Current challenges also include early detection of risk factors. This is a challenging fact, and how we are going to control these risk factors. The solution would lie in the proper making of guidelines towards cardiovascular disease risk management, treatments, and also the implementation of these guidelines. And the second would be the compliance factor. Whatever guidelines that we make, if they are not properly followed by the patient, then the whole purpose of treatment, the whole purpose of risk management, whole purpose of disease management is defeated. And here comes the role of a poly pill. The epidemiology has changed for cardiovascular disease, I have just told. This slide shows that in 1970, communicable diseases accounted for 39% of the total disease load. Non-communicable diseases accounted for 36% of the disease load, and injury and accidents accounted for 25%. Towards 2008, communicable diseases accounted for 27%, 63% accounted for non-communicable diseases, and 10% for accidents and injuries. So from 36% it has grown to 63%, and the projection for 2030 is a further increase from 63% to 70%. The causes of death in India, as reported by WHO in 2010, is 37% because of communicable diseases, 53% because of non-communicable diseases, and 10% because of accidents and injuries. And from all of these 53%, the majority of the deaths are because of cardiovascular disease, and this figure in 2010 was approximately 23 lakhs 33,000. The next is respiratory diseases, cancers, diabetes. I suppose a lot of patients with cardiovascular diseases leading to mortality were also suffering from diabetes. This slide shows the same change in epidemiology. Initially, the developed world had great number of non-communicable diseases. As the time passed, the communicable disease incidence has decreased. The disability adjusted life years lost by coronary heart disease in India in men and women has been increasing over the decades. From 1990, 5.6 million, 4.5, this has gradually increased, and the projection has nearly doubled or tripled from 1990 to 2020. The females, the women are also catching up very fast. The CV mortality in millions, in 1990 it was 2.26 and it has been rising in a ladder-like fashion. The projected CV mortality in millions is 4.77 million in 2020. So we are going to have a very big explosion of cardiovascular diseases in the next 3, 4, 5, 6 years. What are the factors for increase in incidence of cardiovascular disease in India? We all know these factors very well. Probably urbanization is one big reason, stress, reduced physical activity, changing dietary patterns, and even improved life expectancy. As the population grows older, more and more people are likely to suffer from cardiovascular disease, and also an earlier onset of disease. Now in cardiovascular disease, usually the patient doesn't suffer, the patient or the population doesn't suffer from a single or isolated risk factor. The risk factors usually occur in clusters. A person might be suffering from hypertension, diabetes, low HDL, high LDL levels, and even high cholesterol values, total high cholesterol values, obesity. He might be a smoker, he might be using tobacco. So the risk factors are usually a cluster of risk factors, not an isolated risk factor in a particular individual. The situation in India is typical because of cardiometabolic syndrome also, and we have a total of around 60 to 65% male population suffering from abdominal obesity, low HDL values, hyperglycemia and high triglyceridemia. Similarly, in the females, the abdominal obesity is up to the tune of 70% and the hypertriglyceridemia, low HDL values and hyperglycemia are slightly less as compared to the men. We have to detect the risk factors as early as possible to prevent cardiovascular disease. Early recognition of this could happen by proper family history, then screening, assessments and testing for calculating body mass index, blood pressure screening and total cholesterol screening, lifestyle assessment, finding about the food habits, the smoking habit, alcohol habit, use of tobacco and other lifestyle behaviors. Then there are certain major risk factors like hypertension, diabetes, and now I would like to talk about hypertension. We have a lot of drugs for treating hypertension, but inadequate control of blood pressure in spite of regular visit to a doctor is a very common factor. About 50% do not have treatment changed despite persistently elevated blood pressures. And despite of multiple guidelines, elevated systolic blood pressure until it is more than 150 millimeter mercury is left untreated. Only 60% have their systolic blood pressure values reduced to 140 millimeter mercury or less. So out of the total population of hypertension, hardly 40 to 50% are being treated, and out of them hardly 40% achieve target goals. Only 60% have their systolic blood pressure values reduced to target values. The implementation of guidelines for cardiovascular risk management. 2013 ACC and AHA guidelines on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. Individuals with clinical atherosclerotic cardiovascular disease and individuals with LDL-C values more than 190 milligram per deciliter would need high intensity statin therapy to lower the LDL values more than 50%. They are at a very high risk and therefore they need a high intensity statin therapy. In diabetic individuals between 40 to 75 years of age and with LDL-C values between 70 to 190, but without any evidence of clinical atherosclerotic cardiovascular disease, and in individuals without clinical atherosclerotic cardiovascular disease or diabetes, ages between 40 to 75 and LDL between 70 to 189 and have an estimated 10-year ASCVD risk of 75 or higher, 7.5% or higher, they would need a moderate intensity statin therapy, and this could be by simvastatin 20 milligrams per day. So those who are suffering from atherosclerosis and they have very high levels of LDL, they would need a very high intensity statin therapy as compared to those who are not suffering from atherosclerosis and have moderately raised levels of LDL-C. Now about the use of aspirin as primary prevention. Aspirin for primary prevention of cardiovascular events in people with diabetes. The task force has recommended encouraging aspirin use in men aged 45 to 79 years and women aged 55 to 79 years. They are suffering from diabetes, and aspirin therapy should be with 75 to 162 milligrams of aspirin per day and can be used for primary prevention in patients with diabetes. For stroke prevention, guidelines for prevention of stroke in patients with ischemic stroke or TI For patients who are unable to take oral anticoagulants, aspirin is recommended up to 325 milligrams per day, and this is class 1 and level of evidence is A. So those who have had a TIA or those who have had ischemic strokes, for them aspirin has been a recommendation, and the dose of aspirin is 325 milligrams per day. The 2014 AHA and ACC guidelines for the management of patients with non-ST elevation acute coronary syndrome recommends the use of antihypertensives as required, plus antiplatelets and statins. The 2013 ESH, European Society of Hypertension, and ECS guidelines for treatment of hypertension recommends the use of 1, 2 or 3 antihypertensive drugs as required according to the level of hypertension, along with statins and a low dose of aspirin, with the rationale that hypertensive patients often present with dyslipidemia and not infrequently have a high CV risk. So all patients whom we are treating for hypertension should be receiving statins, and they should be receiving aspirin. Now, the European Society of Cardiology guidelines for cardiovascular disease prevention, 2012. The European guidelines on cardiovascular disease prevention in clinical practice recommends that one must reduce the dosage demands in persons who are at a high risk of CVD. By dosage demand I mean the pill burden. Those who are at a risk of CVD, they might be suffering from hypertension, they might be suffering from diabetes, high cholesterol values, and they might be having other risk factors also, and they will be taking a lot of pills. If we could reduce the pill burden, then the compliance increases, and they have said that a randomized phase 2 trial in middle-aged individuals without CVD demonstrated that the polycap formulation could conveniently reduce multiple risk factors. Now, compliance to therapy for secondary prevention, the premier study says that 1/3 of patients discontinue treatment within 1 month of myocardial infarction. A patient who has suffered from myocardial infarction would be requiring beta blockers, AC inhibitors, antiplatelets and statins as secondary prevention drugs. But the story is that only 66% of the patients continue to take these pills for the first month. About 12% discontinue the use of all medications within the first month. 3.7% of the patients discontinue two of these preventive medicines within the first month, and 17% would discontinue one of the medications within the first month. So only 66% are taking all the secondary prevention pills, and a very huge population, 33%, is not taking the secondary prevention medicines. The PURE study also shows that the study showed underuse of low-cost medicines for secondary prevention among participants with a history of cardiovascular disease or stroke. Whether it is myocardial infarction or stroke, the use of AC inhibitors or ARBs was only to the tune of 19.5%, statins were used in 14.6%, beta blockers 17.4%, antiplatelets 25.3%. Over a long duration of time. So where these secondary prevention drugs are needed, there also the use is very limited. Then came the Eureka study. This was carried out in 12 European countries from May 2009 to January 2009, and was used to evaluate the physician's attitude to risk factor control. And you will be surprised to note that the ESC CVD prevention guidelines were followed in only 60%, 55 to 60% of the patients by the physicians in European countries. The ESC and ESH hypertension guidelines were followed in 28 to 45% of the patients by the physicians, and ATP guidelines were followed by 9.1 to 8.1, JNC guidelines to even lesser. And the reasons for this, as told by the physicians, was not, some of the physicians would say that these guidelines are not applicable to their patients, the guidelines are unrealistic, some would say that the guidelines are too confusing, and some would say that they don't have the time to explain the guidelines to the patient. So in countries which are very well educated and they have all the resources, there they don't follow the guidelines. I don't know what would be the situation in this country. Certainly the situation, the scenario in this country would be very poor. And if we are not paying attention to secondary prevention, I don't know what we will be doing for primary prevention. The effects of a fixed dose combination strategy on adherence and risk factors in patients with or at high risk of cardiovascular disease. The Umpire randomized clinical trial. The study design was 2004 patients with established cardiovascular disease or patients at the risk of cardiovascular disease were enrolled between 2010 and July 2011 in India and in Europe. The objective of Umpire study was to assess whether fixed dose combination delivery of aspirin, statin and antihypertensive drugs versus the usual care improves long-term adherence to medication or not. The conclusion was the use of fixed dose combination strategy resulted in significant improvement in medication adherence. Those who were given fixed dose combination therapy, they adhered to their treatment, they were more compliant, and there was a significant improvement in systolic blood pressure and LDL-C values. The adherence was to the tune of 77% in FDC, and in the usual care it was only 23%. There was a threefold increase in compliance. So the reduction of pill burden is a very important strategy in the management of cardiovascular diseases. Non-compliance and survival, as is very obvious, would go hand in hand. Those who are taking all three medications, antihypertensives, statins and antiplatelets, they show a better survival curve, and as they lose the medications, when they take one medication less, they fall down one step, and if they take two medicines less, they fall down 2 steps, and with no medication, you can see the survival curve coming down. In the intra-heart study, there was an exponential rise in MI risk with added risk factors. More the risk factors, there is an exponential rise in the myocardial infarction risk. Smoking, diabetes, hypertension, ApoB by E1 ratio, all 1 to 3 combined, the initial 1 to 3, and with obesity, with psychological factors, and if you combine all the 9 risk factors together, then the incidence of MI increases to the tune of 26 times. The recommendation from elite organizations for improving adherence. European Society of Cardiology, American Heart Association, NHS, American College of Cardiology, and even the textbook of internal medicine by Harrison suggest reducing dosage demand is the most effective single approach towards effective adherence and enhancing the adherence. A fixed dose combination therapy by polycap would reduce the dosage demands. Polycap is an innovative idea to decrease CVD risk with improved compliance. Polycap is one capsule with multiple drugs. It is a hard gelatin capsule containing 3 antihypertensive drugs: hydrochlorothiazide 12.5 milligram, atenolol 50 milligram, ramipril 5 milligram. There is one lipid lowering agent, simvastatin, one antiplatelet, acetyl salicylic acid 100 milligram, which is enteric coated. Now there were issues about bioavailability, Polycap versus those when given individually, and it was found that Polycap maintained the bioavailability. There were no pharmacokinetic interactions between the drugs present in the capsule. 92% of the patients completed the trial. What were the mean changes in blood pressure with individual drugs? When we gave the diuretic, there was approximately 2 mm decrease in systolic blood pressure and 1.3 mm decrease in the diastolic blood pressure. When 2 drugs, a thiazide and a beta blocker, were used, the systolic blood pressure dropped down to 4.7 mm average systolic blood pressure, and the diastolic came down to 3.6. With 3 BP lowering agents, hydrochlorothiazide, beta blocker and AC inhibitor, the systolic blood pressure came down to 6.9, minus 6.9, and diastolic by minus 5. But in Polycap, the range that was recorded was minus 7.4 and 5.6. 7.4 systolic and diastolic came down by 5.6. So we find that there is better control of blood pressure, there is a reduction in heart rate, LDL levels, platelet aggregation. The effects were similar to individual drug regimes. Now, if you give them separately or you give them in a capsule, the effect was the same. 85% of the patients completed their trial in the Polycap arm. So Polycap reduces multiple risk factors with improved compliance. Polycap mean changes in the LDL and platelet function. Both groups showed reduction in LDL levels. Whether you give simvastatin alone or whether you give it in Polycap, the amount of LDL reduction, that is about 8% and 7% in the Polycap, were nearly identical, and there was a similar reduction in 11-dehydrothromboxane B211 when we used Polycap or ASA alone. You use ASA alone, there is a similar reduction in 11-dehydrothromboxane B2 activity. When you use it along with 3 BP lowering agents and ASA, and either in a combination with as Polycap, the reduction is identical. The main changes in BP, LDL and risk reductions. In TIPS 2, a higher dose of Polycap was used. 2 capsules were used. When single dose was used, the reduction was in single digits, and when the double capsule was used twice daily, then the systolic blood pressure was reduced to the tune of 14.7%. The reduction in LDL was also nearly increased by 1.5 times when 2 capsules were used. The last slide is very important, and this shows the projected risk reduction in TIPS 1 study and TIPS 2 study. In TIPS 1 study, only a single capsule was used, and there was a 62% reduction in the coronary heart disease and 48% reduction in stroke. This is a very robust reduction of cardiovascular diseases. And when 2 capsules were used, the reduction of cardiovascular diseases, the coronary heart disease, came down to 69%, and this is 57%. The stroke reduction is to the tune of 57%. The benefits of polypill. There is a significant CV risk reduction, as I have just told. There is improved adherence and compliance. This is the story. The adherence and compliance. You write medicines, and if they are not followed, if the patient stops those medicines, then they are of no use, neither to the patient nor to the doctor. There are the reduced side effects and there is a lot of cost saving. This has generated widespread global interest amongst physicians, patients and policymakers. Now, who can benefit from Polycap? Polycap is recommended to patients with established cardiovascular disease, heart disease, strokes, with or without hypertension. It's not a simple antihypertensive drug. Even in patients of heart disease without hypertension, Polycap is recommended. Similarly, patients with cardiovascular disease with or without dyslipidemia, Polycap can be used. And patients with hypertension and dyslipidemia, Polycap can be used. Here I would suggest that Polycap can be used even in patients with hypertension without dyslipidemia, because as I have just told that the risk factors are not isolated. The risk factors, they are present in clusters, and if dyslipidemia is not present, it's not a contraindication for the use of Polycap. There might be other several risk factors. A hypertensive patient may be a diabetic as well. So large number of patients can benefit from Polycap therapy. In the end, I'd like to summarize by saying that CHD and stroke are one of the biggest killers. Hypertension and or dyslipidemia are major risk factors. Risk factors require early recognition and they require effective control. Majority of the guidelines recommend polypill for effective control of multiple risk factors. And Polycap, as I have shown the studies, TIPS 1 and TIPS 2, is effective, well tolerated solution for the changing epidemiology. Polycap is an Indian solution for a global problem. Thank you.